Hello and welcome back to the Biochemistry for Health Sciences channel. In today's video, we shall discuss hypercalcemia, high levels of calcium in the blood. In hypercalcemia, the total serum calcium is greater than 10.4 milligrams per deciliter. The normal serum calcium is around 10 milligrams per deciliter. If we look at the ionized calcium in hypercalcemia, the ionized calcium would be greater than 5.2 milligrams per deciliter. Now remember that the ionized calcium makes up about 50% of total calcium. Now the blood calcium will increase if there is increased entry into the bloodstream and or decreased exit out of the bloodstream. Now, increased entry into the bloodstream can happen through increased absorption from the GI tract, increased bone resorption or demineralization, so bone calcium is coming out into the bloodstream, as well as increased reabsorption of calcium from the renal tubules back into the bloodstream. Decreased exit happens when there is decreased excretion of calcium in the urine. Now, the two major causes of hypercalcemia include, number one, primary hyperparathyroidism, which is mediated by parathyroid hormone, and number two, cancer, which is non-PTH mediated. These two causes make up about 90% of all cases with hypercalcemia. The other causes of hypercalcemia include tertiary hyperparathyroidism, which is mostly due to chronic kidney disease, excess vitamin D, immobilization, as well as medications. So when one sees a serum total calcium greater than 10.4 milligrams per deciliter, the first question one needs to ask is it really hypercalcemia? This is because there is a condition called pseudohypercalcemia. In this case, the total serum calcium is elevated, but that's due to increased serum proteins. So whenever there is an increase in protein, serum proteins, such as the globulins, example, the paraproteins that we see in multiple myeloma, or if there is an increased albumin that we see in, for example, athletes consuming high protein diet. So whenever there is an increase in serum protein, that may lead to an increase in total serum calcium. Recall from a previous video when we measure total serum calcium, we are measuring not only the ionized active calcium, but we are also measuring the bound calcium, which includes calcium complexes as well as calcium bound to protein. So if there is increased protein, there will be more calcium bound to protein, and that will increase the total serum calcium. We can differentiate pseudo-hypercalcemia from genuine hypercalcemia by carrying out the ionized calcium test. So when we do the ionized calcium in pseudo-hypercalcemia, the ionized calcium will still be normal, although the total serum calcium is increased. In genuine hypercalcemia, the ionized calcium will be greater than 5.2 milligrams per deciliter. Let us first look at the two most common causes of genuine hypercalcemia. The first is primary hyperparathyroidism, which is the most common cause in outpatients. And the second is cancer, which is the most common cause of hypercalcemia in hospitalized patients. The most common cause of primary hyperparathyroidism, which accounts for about 85% of cases, is adenoma in one gland. And this adenoma in that one gland produces excessive amounts of parathyroid hormone. Adenoma is a benign tumor due to a non-cancerous abnormal growth of cells. These cells may be genetically different from one another, but they do not invade nearby tissue. The second most common reason that accounts for 15% of cases with primary hyperparathyroidism is hyperplasia. This is the reversible increase in the number of normal-looking cells, and this hyperplasia occurs in two or more parathyroid glands. Because of this increased growth of cells, these glands produce too much, excessive amounts of parathyroid hormone. And this is most often due to chronic kidney disease or to vitamin D deficiency. Now, rarely, less than 1% of these cases involve multiple adenomas, which is adenoma not just in one gland, as we saw here, but in more than one gland. And some of these cases might even involve carcinoma. This is a malignant form that invades surrounding tissue. So unlike adenoma, which is benign, carcinoma is invasive. Primary hyperparathyroidism has a higher incidence in postmenopausal women. So what happens if the parathyroid gland produces excessive amounts of PTH? As we discussed in an earlier video, PTH will cause the increased resorption of bone. That is the demineralization of bone. It will basically break down bone and release calcium as well as phosphate. And this calcium and phosphate will enter the bloodstream, and it will tend to increase the levels of serum calcium as well as serum phosphate. Another important site of action of parathyroid hormone are the kidneys. In the kidneys, the PTH will increase calcium reabsorption, and that calcium reabsorption is going to increase serum calcium levels. Another effect of PTH on the kidneys is that PTH activates the enzyme 1-alpha hydroxylase in the kidneys, and that will cause more vitamin D to be converted into calcitriol. So the calcitriol levels will start increasing, and calcitriol, as we talked about in an earlier video, will cause its effects such as increased calcium and phosphate absorption from the GI tract, increased renal calcium phosphate reabsorption, as well as bone demineralization, and all of that is going to increase the calcium as well as phosphate. Another effect of PTH on the kidneys is that PTH decreases phosphate reabsorption. That means it increases the excretion of phosphate. So although the phosphate here seems to have increased from these various effects, the net result is that this phosphate will be excreted. So that means PTH, the net effect of PTH, it increases serum calcium, but it reduces serum phosphate. So in this primary hyperparathyroidism, we see increased parathyroid hormone, and we also see increased calcium. Now, normally when serum calcium increases, so if we increase serum calcium, the parathyroid hormone secretion should decrease. So that's what we see in a normal situation. However, in primary hyperparathyroidism, we see that the calcium is not effectively suppressing the PTH secretion. So you can see the curve for primary hyperparathyroidism has shifted to the right. So normally the set point, that is this point here, is around 9 milligrams per deciliter to inhibit 50% of PTH secretion. But in primary hyperparathyroidism, you can see the set point has now moved to, in this case, you can see almost close to 10 milligrams per deciliter. So we need a much higher calcium concentration in the serum to inhibit the same 50% secretion of parathyroid hormone. So what is the reason for this? One of the suggestions is that the parathyroid gland becomes less sensitive to calcium levels. So the adenoma or the hyperplasia will increase the number of chief cells in the gland that will produce more PTH. But these glands have fewer functional calcium sensing receptors. These are the receptors that respond to calcium, typically 30 to 70% of normal values. So due to the decreased density of these calcium sensing receptors, these parathyroid glands become less sensitive to calcium in patients with primary hyperparathyroidism. Now, there is a good way to represent this relationship between parathyroid hormone and calcium, and that is the use of a PTH-calcium nomogram. In this graph, the PTH level is shown here on the y-axis in picograms per milliliter. Remember, PTH is a hormone, so the concentration of these hormones are very, very low. We are talking about picograms. Then on the x-axis, we have serum calcium, which is in milligrams per deciliter. If we were to plot the values of PTH and their corresponding serum calcium levels for each patient with primary hyperparathyroidism, you see that most of the patients will fall around this dotted area. About 80% will fall in this dotted area. And then there'll be a few that will be found outside this dotted area. So this blue line here represents the boundary between primary hyperparathyroidism as well as normal individuals. Now in real life, there is always variation. So what we see practically is about 98% of patients with primary hyperparathyroidism will have high calciums greater than 10.5, but there's going to be a small amount of people who will have a normal calcium level, while about 82% of the patients with primary hyperparathyroidism will show a PTH greater than 60 picograms per mil, and about 18% will show a normal PTH. Now let's look at the second major cause of genuine hypercalcemia, and that is cancer. We'll look at two aspects. One is humoral hypercalcemia or malignancy, and the second is local osteolytic hypercalcemia. Now some cancers like squamous cell carcinoma in the skin or in the lung, as well as various solid organ cancers. These are cancers that form lumps in solid parts of the body, such as the breast and prostate. These cancer cells release a protein called PTH-related peptide, or PTH-RP. This PTH-RP has amino acids 1 to 13 that are very similar to PTH. This PTH-RP that is released by these cancer cells will go to the kidneys and increase calcium reabsorption, especially the distal convoluted tubule, and this is going to lead to elevated calcium or hypercalcemia. The PTH-RP may also decrease phosphate reabsorption, just like parathyroid hormone, and this is going to cause low serum phosphate. Like parathyroid hormone, this PTH-RP will go to the bone and bind PTH receptor type 1, and this will increase the formation of osteoclasts. And the increased number of osteoclasts is going to lead to increased bone resorption, and that's going to release calcium as well as phosphate from the bone into the bloodstream. So this elevated calcium is going to go to the parathyroid gland and is going to inhibit PTH secretion. So in this case, we have increased calcium, hypercalcemia, but we have decreased PTH. In local osteolytic hypercalcemia, the cancer cells that are associated, for example, with breast cancer, multiple myeloma, lung cancer, lymphoma, these cancer cells invade the bone tissue. In the bone, the cancer cells start releasing various biomolecules such as cytokines, and these cytokines activate the activity of osteoclasts. Remember, osteoclasts are the cells that break down bone, so this increased osteoclast activity is going to cause increased bone resorption. The bone gets demineralized, and the calcium and phosphate from the bone will come out into the bloodstream. This will lead to an elevated calcium, which will then go to the parathyroid gland and decrease PTH secretion. So in this case, we see elevated calcium but low PTH. So if we go back to our PTH-calcium nomogram, you can see primary hyperparathyroidism shown in blue here, and then you can see hypercalcemia of malignancy, the second most important reason, cancer. And in this case, you can see although the serum calcium is high, serum calcium is elevated, the PTH is low. You can see the PTH values are low. Okay, so this is a very nice way to differentiate the two major causes of hypercalcemia. So this is a little bit about the two major causes of hypercalcemia. In the next one or two videos, we'll look at the other causes of hypercalcemia. Until the next video, once again, thank you very much for supporting and watching this channel. Goodbye and have a wonderful day.